Our webinar topic today is Skin Deep, Visual Skin Assessment Competency for Perioperative Nurses. Susan Scott is currently a medical educator with the University of Tennessee Health Science Center, Office of Graduate Medical Education in Memphis, Tennessee, and an independent consultant for Scott Triggers PLLC. ARN would also like to thank Marie Brown Etris for her contributions to this webinar. Here are the presenters' disclosures. After today's presentation, you should be able to review the anatomy and physiology of pressure injury development, common pressure points, and location of pressure injury in various surgical positions. Identify best practices for assessment, prevention, and documentation to improve competency and skill of the perioperative nurse. Now I'd like to turn the program over to Susie to begin.
Hello everyone, this is Susie Scott. I want to start by talking about the skin in general before we get into some of the complications. The skin is the largest organ in the body, averaging 7 square feet. It serves multiple functions, including protection and immunity. The acidic pH of the skin inhibits pathogens, which protects against infection. It provides thermoregulation or control of the temperature of the body and insulation to conserve heat. You think about now that we're in winter, we get goosebumps when we get cold. And in the summer, we sweat when we're hot, all functions of the skin. Sensory perception, or the ability to feel pain, temperature, or pressure, protects us from harm, or it can serve as a warning of physical issues. The skin also synthesizes vitamin D, and it provides for communication or self-expression. You've heard the saying that beauty is only skin deep. Now, there are multiple factors that can affect the integrity of the skin, including advancing age, sun exposure, hydration, humidity, the use of harsh soaps and chemicals, nutrition, and medication. The anatomy and physiology of the skin is very complex, but really cool. There are 2 main layers of the skin, the epidermis and dermal layers. Now, I want you to visualize, if you will, a sugar cube. A sugar cube is basically about 1 centimeter square. So if we had 1 square centimeter of skin, it would contain 15 sebaceous glands, 25 pressure receptors, 100 sweat glands, 200 nerve endings, 1 yard of blood vessels, 12 heat sensors, 2 cold sensors, 4 yards of nerves with 3,000 sensors for communication, and 3 million cells constantly renewing themselves in 1 square centimeter of skin. So the epidermis is composed of several layers. The top layer, or the stratum corneum, is basically dead keratinized cells. The lucidum is the layer that may be thicker in certain areas of our body, like the hands or the sole of the feet, and it's completely absent in the areas like the eyelid. The granulosum layer is the one that gets stained when you get a tattoo. The spinosum is the prickly layer, and then the basali, or the genitavum, are the area where growth factors, hormones, and vitamins will migrate upward within 2 to 3 weeks after an injury. And then we have the basement membrane, which separates the dermal from the epidermis layers. Now, this basement membrane is composed of a protein called fibronectin, and it's an adhesive glycoprotein that anchors the epidermis to the dermis. And this is the layer that gets affected when you form a blister. The dermis is the thickest layer of the skin, and it contains fibroblast cells, all those blood vessels that I talked about earlier, and also can be very painful when it's disrupted. Collagen is the most abundant protein in the body. And normal human dermis is composed primarily of type 1 collagen, a fiber-forming collagen that gives the skin its tensile strength. Elastin is also another protein that gives skin its elastic recoil. We really want more elastin when we start to get older because that's what causes our skin to sag and droop. If the epidermis is the shirt and the dermis are the pants, then the collagen is the belt that hold the two together. So there are numerous types of skin damage that you may see in surgical patients, including pressure injury, medical device-related pressure injury, medical adhesive-related skin injuries, and there can also be burns and vascular damage in combination with ischemia or anticoagulants. And we're going to discuss all these. So I want to talk about the etiology of a pressure injury. So I'm going to tell you a little story. We start with a body, either with a low BMI and very protruding bony prominences, or we may have a high BMI, which is over 40, where the extra weight increases the force of pressure on the bony prominences and adjacent tissues. Then we're going to add sustained high pressures to these bony prominences from immobility, such as a lengthy OR procedure and prolonged immobility before and after surgery. We then have significant tissue distortion, which leads to stress and strain on the cells at the microscopic level. These make the cells very unhappy. Once the cells are damaged, they can become ischemic, and the result can be a deep tissue pressure injury. This repeated exposure to tissue distortion and prolonged unrelieved pressure from procedures increase the risk for pressure injury. And this may explain why reoperations have been identified as a significant risk factor in the OR pressure injury research findings. The time it takes to develop these injuries can be as little as 1 hour, as reported by the GRAP study using subepidermal moisture scanner. And Schoonhoven and colleagues found that for every 30 minutes a surgery went beyond the 4-hour mark, the risk for pressure injury increased by approximately 33%. So let's talk about visual skin assessment. Now, there's a difference between a skin inspection, which is just observing the skin, and performing a visual skin assessment. The assessment determines the presence or absence of a pressure injury after visualization or direct palpation of the tissue. All surgical patients should have a full body skin assessment prior to and after surgery. So the visual skin assessment itself may be unreliable immediately post-op or in darker skin tones. There are some limitations. It's not going to detect early damage subdermally or at the microscopic signs of damage. But it's very important that you check for erythema post-operatively. You want to use palpation or checking for capillary refill, warmth, or changes in the skin texture. If erythema or redness is observed, you want to check for blanchable versus non-blanchable erythema. You do this by pressing your finger firmly against the area of erythema for 3 to 5 seconds. Then release. If the tissue turns white, it's considered blanchable. For blanchable erythema, you should offload the pressure and recheck in 1 hour for resolution of the redness. And this should be reported in your handoff. If the tissue is non-blanchable erythema over a bony prominence that's associated with the surgical position, this could be considered stage 1 and may be indicative of reactive hyperemia and capillary damage. So, according to the National Pressure Injury Advisory Panel, a pressure injury is a localized damage to the skin and underlying soft tissue over a bony prominence related to a medical or other device. The injury can present as intact skin or open ulcer and may be painful. The injury occurs as a result of intense and prolonged pressure or pressure in combination with shear. The tolerance of soft tissue for pressure and shear May also be affected by microclimate, nutrition, perfusion, comorbid conditions, and the condition of the soft tissue. So in perioperative pressure injuries, what is problematic is that we may not see that microscopic damage visually until 48, 72 hours after surgery. And there's some deep tissue injuries, like the one in this photo, that may take up to 7 days for the visual skin injury to be present. And where are our patients 7 days after surgery? Most oftenly, they're at home. You want to be aware of high-risk pressure points in each surgical position. To perform a full-body skin assessment, you need to thoroughly inspect the skin with special attention to the pressure points and bony prominences. You want to look at the lower extremities, skin folds, crevices, and skin under medical devices. Palpation is used to identify the skin texture and duration or skin temperature or tenderness. All patients should have a skin assessment prior to surgery. This is a critical competency for the perioperative staff. Accurate, timely, documented skin assessments establish the baseline and drive prevention protocols. Early recognition and communication can set the standard for aggressive care planning that may prevent new injuries from progressing to the more severe stages. All blanchable and non-blanchable erythema should be observed and reported until resolved. OR nurses and perioperative staff need to learn how to assess the skin systematically while performing your routine tasks, such as dressing the patient, undressing the patient, applying compression stockings, or moving the patient onto the table. Some of the best practices I've seen are full-body skin assessments for all cases over 2 hours, with a 4 eyes visual skin assessment between the OR and peri-anesthesia staff at the end of the case handoff. So I want to thank the National Pressure Injury Advisory Panel for allowing me to utilize their illustrations and definitions for the stages of pressure injuries. For more information, you can go to their webpage for additional definitions and resources. So again, this is our healthy skin in lightly pigmented individual and in darkly pigmented individuals. A stage 1 pressure injury is non-blanchable erythema of intact skin. It may appear differently in darker pigmented skin. There may be presence of blanchable erythema or changes in sensation. The patient may complain of pain. Color changes that do not include purple or maroon discoloration, these would indicate a deep tissue injury and should not be classified in a stage 1 pressure injury. These are some clinical examples of a stage 1 pressure injury. Non-blanchable erythema of intact skin on the medial malleolus, the heel, and the medial metatarsal on the foot. Darkly pigmented skin, there may be some differences in how to assess these because you cannot visualize reactive hyperemia. You may look for a darker discoloration of the skin surrounding the next to the bony prominence. You may need to moisten the skin to aid in identifying any color changes. Palpate for induration. This is an example of a stage 1 pressure injury in darkly pigmented skin. This particular case was brought to my attention by my PACU nurses. They had contacted me for an area they thought was stained with betadine. The patient had been in prone position on a towel roll, and he ended up with this injury in the lower costal margin, a stage 1 pressure injury. Stage 2 pressure injury is partial thickness skin loss with exposed dermis. The wound bed is viable. It's pink or red and moist. It may also present as a blister, intact or a ruptured serum-filled blister. If you see fat or any other deeper structures, then that is not indicative of a stage 2 pressure injury. This is an example of a partial thickness skin loss with exposed dermis. And you can see the dots in this slide. That's where those epidermal appendages start to have cellular migration that leads to epithelialization of a partial thickness wound. Stage 2 pressure injury should not be used to describe any type of incontinence-associated dermatitis, like this photo here, or any moisture-associated skin damage from incontinence, intertriginous dermatitis, medical adhesive-related skin injury, or skin tears, burns, or abrasions. A stage 3 pressure injury indicates full thickness skin loss. This is where you will have adipose tissue or fat is visible in the ulcer, granulation tissue, and epibole, which is the rolled wound edges, are often present. Slough or eschar may be visible. The depth of the tissue damage varies by your anatomical location. Areas of significant adiposity or fat can develop deep wounds. You can also have undermining and tunneling. The fascia, muscle, tendon, ligament, cartilage, and bone are not exposed in a stage 3 pressure injury. So this is a stage 3 pressure injury with full thickness skin loss. You can see here there is some areas of slough, which is indicative of necrotic fat. And you notice the whiteness of this area surrounding the wound. That is maceration from excessive drainage. A stage 4 pressure injury is full thickness skin and tissue loss. You can have exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone in the ulcer. Slough and eschar may be visible. You may have the epibole, undermining or tunneling. The depth, again, varies by anatomical location. If you have slough or eschar and it obscures the extent of tissue loss in the wound, it's considered unstageable. This is a stage 4 pressure injury in a clinical patient. You can see the striations of the muscle, and that's the trochanter bone that can be lightly palpated. A deep tissue pressure injury is what we may see in some of our surgical patients. A deep tissue pressure injury is intact or non-intact skin with localized area of persistent, non-blanchable red, deep red, maroon, or purple discoloration. You can have the epidermal separation, revealing a dark wound bed or a blood-filled blister. Pain and temperature change often precede the skin color changes. And this is important because if your patient wakes up from anesthesia and they're complaining of severe pain and it's not associated with the surgical incision, this could be a sign of a deep tissue injury, pressure injury, or even a nerve injury. And that should be reported in the medical record. So these wounds may evolve rapidly over the hours and days to reveal the actual extent of the tissue damage, or in minor cases, they could resolve without tissue loss whatsoever. If there is necrotic tissue or subcutaneous tissue, granulation tissue, fascia, muscle, or other aligned structures are visible, this indicates it's a full thickness pressure injury. And this is one example of that. This stage, deep tissue injury, should not be used to describe traumatic, neuropathic, or dermatological conditions such as the photo here is a traumatic bruising. You need to know the difference between a DTI and a bruise, vasopressor ischemia, or Coumadin necrosis. and this is something that needs further definition in the operate setting, particularly when we're using tourniquets in patients who have been anticoagulated. Again, we look at this perioperative pressure injury. This is a patient 48 hours after a CABG, and you can see the classic purple discoloration. There's also an irregular shape here that indicates there's significant tissue distortion and shearing. What we can also see is the epidermal dermal layer that is starting to separate. If you review the forensic literature, a deep tissue injury in evolution is very similar to tissue decomposition in a deceased patient. I usually refer to this as blistering, but in the forensic world, this is known as skin slippage. An unstageable pressure injury is full thickness loss, but you don't know what stage it is because it's obscured by the eschar or eschar and slough. Once this has been debrided, you can determine what the stage of pressure injury is. These photos are black eschar on an ankle and also on a heel. Unstageable pressure injury. This is an unstageable pressure injury that's obscured with slough, which is necrotic fat, and eschar. You can't confirm the stage until this has been removed. And this is an example of an unstageable pressure injury. Generally, you won't see these immediately from a postoperative period. These are existing ulcers that have already declared themselves. Medical device-related pressure injury is a new category of pressure ulcers. They result from devices. It's a localized injury to the skin or underlying tissue as a result of sustained pressure from a device. It's estimated that the incidence of medical device-related pressure injuries is about 34.5% of all hospital-acquired pressure injuries, and it's up to 50% of the population in pediatrics. It's estimated 70% of medical device-related pressure injuries are on the head. The definition by MPUAP is that MDRPIs result from the use of devices designed and applied for diagnostic or therapeutic purposes. It conforms to the shape of the device. And you can see in this photo a pressure injury from endotracheal device. There are multiple medical devices in the operating room that can contribute to pressure injury. If you witness a pressure injury from any of these devices, you need to report it and start a real-time root cause analysis so that you can implement countermeasures to negate the negative effects of these different types of devices. Medical adhesive-related skin injury, or MARSI, is a term that was defined by the Wound Ostomy Continence Nurses Society. They have created a best practice consensus statement. MARSI is the occurrence of erythema or skin abnormalities such as a vesicle, bulla, or blister, erosion, or tear that persists 30 minutes or more after adhesive removal. MARSI is an example of a top-down skin injury where that epidermal dermal layer gets stripped off. These are the different types of MARSIs that you can see in all settings. It mainly can affect the dermal layer, and that's why there can be significant pain with these types of injuries. The most common injuries you see in surgery can include skin stripping and skin tears when tape is removed. An average surgical patient may have 6 or more adhesive devices, so this is something to consider when you're planning your care. These are some of the different product categories that we may see in the surgical setting that are adhesive in nature. One thing that I would caution against is using tape for positioning, particularly in obese individuals with pannus or breasts. When removing this tape, we have seen injuries that can cause painful lesions that can increase the patient's risk for infection. Another type of injury you may or may not see is related to chemicals or burns. These can be caused from prep solutions, electronic devices such as bovie pads, cautery, or warming devices that can cause burns if improperly used. This is a example of a chemical burn to the buttocks area from pooled solutions. The picture to your right is a burn from a device that was not allowed to cool after it had undergone immediate use steam sterilization. So let's look at some of the pressure points and the various surgical positions. Though we don't have an accurate number of OR-related pressure injuries, we do have incident rates based on current research findings. Orthopedic is number one, followed by trauma, cardiac, spine, and general surgical procedures. We need a lot more evidence in this area. The most common location for pressure injuries in the research that has been published is consistent with the supine position. Supine is the most common surgical position and is associated with the largest number of pressure injuries. There's one study that estimated 85.1% of subjects were in supine position. And these are the pressure points that are associated with that position. A pressure injury of the occiput can result in alopecia, hair loss, which may be permanent or temporary. It's the most common site for pressure injury in pediatrics, particularly in cardiac surgery, and that's related to the weight distribution of the head. And as you can see from this anatomage photo diagram in the center, there is very little padding between the occipital bone and the skin. The current recommendation is to reposition the head every 30 minutes during the surgical case. So my question goes out to who owns the head during surgery, and are they aware of these recommendations? These anatomage images demonstrate the reason why the sacrococcygeal area is vulnerable in the supine position. The tissue can be easily compressed by this bony prominence, which is quite sharp. So we have damage to the sacral area. And in addition to the sacrococcygeal area, the buttocks is also very vulnerable. There's pressure and tissue distortion of the buttock tissue in the flat supine or lithotomy position. The photo to the left demonstrates this prolonged pressure over that area that resulted in a deep tissue pressure injury. And then the photo on the right demonstrates a pressure shift when a patient is planed. So you can actually redistribute the pressure and cause it to be more intense on one side by changing the position here. Heels are particularly vulnerable due to the calcaneus bone and direct pressure on a surface. And in the lithotomy position, we have some of the same pressure areas as in the supine, but you also have to pay particular attention to the thoracic vertebrae, the lumbar area, and where the sacrococcygeal area meets the cutout, perineal cutout of the OR table. There have been reported injuries in that particular area. You have to be cautious of the lateral aspect of the legs and the heels, particularly when you're putting them in stirrups. Okay. Prone position pressure points are consistent with the dependent position, the forehead, eyes, chin, ears, anterior shoulder, the breast, and the chest. There have been reports of ruptured implants or pressure injuries from ports. So you may want to consider extra padding for those areas and proper placement. We've had reports of lower costal margin injuries, the iliac crest, and those bony prominences are vulnerable. One study I reviewed had the genitalia at a 7.7% injury rate. The knee, shin, dorsum of the feet, and the toes are all vulnerable. I would encourage you to do annual clinical competencies and make prone position one of your priority educational activities. By documenting your clinical competencies on these positions, you're also going to protect yourself from litigation. Trendelenburg position, again, we have the same positions as supine, but you also have significant tissue distortion. So there may be problems in the buttocks and also the heels. The lateral position is consistent with which side is place dependent. So you want to make sure that you include laterality in your op reports and your handoffs. These are some of the areas that may be vulnerable, but it is underreported in the literature. So the documentation and handoff documentation is critical to record your assessments and interventions and to pass crucial information across the continuum of care. Your words can really protect you from litigation. So in your verbal handoff, you want to set the expectation for the next level of care if you identify any injuries, such as the photo here. When an injury is identified, you should stage it, describe it, measure, and document in the medical record. You want to include location, laterality, right or left, and any important factors that may have contributed to the injury, such as devices used. This can set the stage for your real-time root cause analysis. As a wound ostomy continence nurse, we always measure the wound in centimeters, record the length and the width and the depth if applicable. Structured standardized communication tools such as IPASS shown here or SBAR are recommended. We should include the surgical position, the time on the table, and risk and skin assessments during all handoffs. AORN states that the perioperative RN should collaborate with the peri-anesthesia RN to identify injury from positioning. In conclusion, preoperative skin assessment is a critical competency of the perioperative staff. Accurate, timely, documented skin assessments establish that baseline and drive your prevention protocols. This communication can set the standard for this early aggressive care planning, which may prevent new injuries from progressing to the more severe stages. And with that, I want to thank you for your time and attendance.
Thank you, Susie, for sharing your knowledge and expertise on this important topic. I'd like to remind our listeners, for you to receive contact hours for this presentation, you must complete the learner evaluation. Complete the evaluation by using the link in your purchase confirmation email or by visiting the AORN website. Once you have submitted your evaluation, you can print your certificate. Thank you all for joining us today. This concludes our Nursing Continuing Professional Development activity.